Okay. Yeah, maternal history, 25 years old mother, consanguineous parents, gravid 1/1, and no history of abortions, okay. No IUGR, nor prom, and no history of drug intake. There is history, they're newborn, 38 weeks, born by emergency cesarean section due to fetal distress, and no history of first asphyxia, nor SCGA, and maybe require only initial resuscitation steps. Day 1, this baby came with severe dehydration, lethargic, tachypnic, subcostal retraction, lethargic, and with severe abnormal cry. Vital data, respiratory rate slightly elevated, respiratory rate was 70 per minute, and heart rate was 150, which is normal, blood pressure was 65/40, and the capillary fill time was more than 3 seconds. Examination and admission, he was lethargic, crying, and his weight is 2.6, and length is 50, and as you see, his weight is minus 2.5% ACDS, and length is 50 centimeter minus 1.1 ACDS, and head circumference 35.5 minus, more or less, minus 0.1, and with mild dehydration, but no dysmorphic features, and the heart sounds are normal, first and second heart sounds. BBG on admission, pH was 7.1, bicarbo 3.9, severe metabolic acidosis, but the X-ray, normal X-ray. NICU, at the NICU, he was put on mechanical ventilation, SIMV, BIB was 12, BIB was 4, the baby received anti-shock measures and maintenance fluids, and he was NBO. We received antibiotics as well, plasma, dopamine. This was 10 years ago, Dr. Yasser. And dopamine 10 mic per kg per minute, and IVIG, and BBG pH was 7.2, and bicarb was 7, still acidotic, and they received a bolus of saline. TBC, hemoglobin was 8.4, TLC was 2.7, blood was 313,000. Potassium was normal, sodium was normal, creatinine was elevated 1 milligram per deciliter, glucose was 300 milligram per deciliter, in iron was 1, blood culture and urine culture were requested. Day 2, the baby was metabolically acidotic, still on SIMV with the same parameter of BIB and BIB, and BBG was repeated. And this is various BBG, pH was 7.1, and with bicarb 5.5. After 5 hours, still 7.1, and bicarb was 7, and 3.5 hours, 7.1 pH, and bicarb was 9.6, and the BBG few hours afterward, still 7.2, and bicarb was 11.2. We received antibiotics and plasma and metronidazole and hydrocortisone. Potassium was low, 3.1. Sodium was hyponatremic. Creatinine was increasing, 1.2. Glucose 119. Capillary fill time was less than 5, more than 3. Urea 27.8 milligram per deciliter, and lactate was elevated 6.5 millimole, and the normal was less than 2.5 millimole. Baby was metabolic acidotic in day 3 with high level of lactate and high anion gap with mechanical ventilation in the same setting, and was received bicarb. BBG pH was 7.2, bicarb was 13, CO2 was 13, and bicarb was 6.7. Abdominal ultrasound, hepatomegaly, mild ascites, and transcranial ultrasound, no abnormality detected. Day 4, vital, more or less appropriate, blood pressure 74/42, heart rate was 167, slightly increased, urine output was high, 7 milliliters per kg per hour, capillary fill time was 3 seconds, pH 7.5, and bicarb was 18. he was still on dopamine and dobutamine, 5 and 10 mic per kg per minute. Patient was extubated, put on nasal, CPAP, and pH was 7.3, and bicarb was 20. TBC was 9.1, TLC was 3.3, and platelet count was 27,000. Thrombocytopenic. Potassium was low normal, sodium was 141, still creatinine is high, 1.1, glucose 99 milligram per deciliter, INR is 1, urea 40 milligram per deciliter, lactate was 25, and normal less than 2.5 millimole, pyruvate was slightly high, 1.8 milligram per deciliter, ammonia was 409 micromole, and the maximum value was 80 or 90. Actually, embryonic metabolism was suspected, and extended metabolic screen and MS-TMS was requested. Day 6, I was on nasal oxygen and vital data, heart rate, respiratory rate, and capillary fill time all was in normal. I received magnesium sulfate due to hypomagnesemia, and we started trophic feeding, and PBG pH was 7.5, and bicarb was normal or even slightly elevated. The results for MS-TMS was still pending. Blood culture and urine culture results were available and no worse. Baby put on oxygen in the incubator, and the pH was 7.5, CO2 was 30, and bicarb was 24.5. In examination, normal detected except both suckling and mild hepatomegaly. Feeding was 7 ml per 3 hours, nasogastric tube feeding, and medication, antibiotics, Lasix, dopamine, dobutamine, and still on magnesium and hydrocortisone. Day 8, transcutaneous oxygen saturation was 94. On the right, the nasogastric tube feeding 15 ml every 3 hours. Body weight was 2.4 kilogram. It's circumference 35. To be and the plan was to increase the feeding and waiting for the metabolic screen results. Day 10, feeding increased significantly. Hemoglobin was 11.2, TLC improved. It was before 2.4 and 2.7. Now it is 5.4. Platelets was low. Now it is 107. And CRB was normal. We plan to increase the feeding and trial of total feeding as well. And the results for the metabolic screen and TMS was no, it's still pending. It was vitally stable, no fever, no vomiting. On the same medication, the gastric tube, 50 ml every 3 hours. And the results still not available yet for the MS. The dose of dopamine and dobutamine were weaned, metronidazole was stopped, and magnesium sulfate as well. And the dose of hydrocortisone was weaned and stopped, and the results still not available. Day 15, no vomiting, no fever, dopamine, dobutamine, hydrocortisone was stopped. Hemoglobin was 10.6, TLC was 5.4, platelet 174, CRB was normal, the results still pending. He was active, well doing, no abnormality detected, in antibiotics, L-carnitine, and waiting for the MS-TMS. Day 17, 7.4 the pH, and bicarb was 18, and the intravenous fluids was 130 cc per kg per day, and glucose was 12.5%. And protein restriction was done to 0.25 gram per kg per day. BBG, pH was 7.3, and bicarb was 11.9, and I received intravenous fluids and glucose 12.5 gram per deciliter, and the protein was on 0.5 gram per kg per day, increase from 0.25. No abnormality detected on exam except for mild hepatomegaly, and protein increased to 0.75 gram per kg per day, and BBG was 7.3 BH, and bicarb was normal. At this point, the MS was available, and it was normal MS TMS, which I was surprised. And at this time, I have to contact the consultant of the metabolic, and I asked him to repeat this test. And the results came back. And the diagnosis was made methylmalonic acidemia. And the vitamin B12 and biotin was added. Day 20, in point of metabolism, the diagnosis was made, methylmalonic acidemia, and antibiotics, L-carnitine, biotin, B12 intravenous fluids, ammonia and anion gap was requested, and he was given Ducal formula and Maximid formula as well, on the same medications and intravenous fluids, and the results for ammonia and the chloride was still not available. Here, as you see, ammonia was slightly high, anion gap was 15. Day 23, the weight was the same, 2.4 kilogram, and Ducal Maximid formula, and intravenous fluids as well, and sodium was normal, potassium normal, chloride 108, ammonia was 186, and caloric intake was 100 kilocalorie per kg per day. Patient was vitally stable on the same regime for the Ducal and for the methylmalonic acidemia and Maximid formula, and urine output was normalized 2.6. Antibiotic was stopped, and there was a plan for discharge. Patient discharged after 28 days of admission. The diagnosis was made methylmalonic acidemia, and this is the discharge plan on L-carnitine, biotin, vitamin B12, and the weight on discharge was 650 kilogram, and on Ducal formula and Maximid formula as well. This is trying to summarize the patient. He was 19 days old, came with poor feeding, vomiting, lethargy, severe cry, severe dehydration, with respiratory distress, resistant acidosis, hyperammonemia, neutropenia, thrombocytopenia, anemia, and abnormal kidney function. And actually, yeah, this patient, when he came about 12 p.m. nighttime, for 11 and a half at night, with severe cry, severe abnormal cry. Nobody notes that there is something wrong. The diagnosis, we put sepsis, central nervous system disease, cardiopulmonary disease, or gastrointestinal tract obstruction, or metabolic disease as well. And this is the summary. 19 days old. Neutropenia, thrombocytopenia, anemia, abnormal kidney function. After sepsis ruled out by urine culture and the blood culture, bone of metabolism was suspected, and methylmalonic acidemia was diagnosed. One management is protein restriction with adequate calories and special form of methylmalonic acidemia, Ducal and Maximid formula, and vitamin B12. All the abnormal lab results to return it to normal. So the diagnosis was methylmalonic acidemia. Now we will go through the definition. The methylmalonic acidemia is a heterogeneous genetic metabolic disorder that characterized by the accumulation of methylmalonic acid and methylmalonyl CoA in body fluids without hyperhomocysteine. There's two forms, vitamin B12 responsive and vitamin B12 non-responsive, and the non-responsive is due to complete enzyme deficiency, they call it MUD0, and partial enzyme deficient, they call it MUD-. The mode of inheritance is autosomal recessive. The incidence is 1 in 50,000, but due to it is more common in countries where consanguinity is high, as in our developing countries. Clinical manifestation of methylmalonic acidemia presents from at the age of 1 month till 1 year with different varying manifestations from poor feeding, vomiting, dehydration, shock, hypoglycemia, hyperammonemia, hyperglycemia, with high anion gap, metabolic acidosis, if left untreated, can lead to coma and even death. And there is organ involvement like central nervous system and bone marrow, and the kidney as well may be affected. Severe form can be manifested with abdominal distension, lethargy, hypotonia, even convulsions, leukopenia, thrombocytopenia, anemia, severe metabolic acidosis, and elevated ammonia level for the neonatal age. Mild form, there's a clinically it is variable manifestations from feeding difficulty, hypotonia, recurrent vomiting, metabolic acidosis, neutral. We mentioned 50% mortality at 10 years of life, and neurological and cardiac with neurological, cardiac, and renal manifestations. Early diagnosis requires the possibility of metabolic disease should be considered in any sick neonate or has motor or mental affection, a positive family history of unexplained child death, and post-consanguinity as well. In these conditions, inborn of metabolism should be required, should be suspected, I'm sorry. If inborn of metabolism is suspected, we have to think the clinician should immediately check on the clinical status of the baby, and inborn of metabolism consultant should be consulted, where specialists request urine for organic acid and other labs, and we have to report the clinical findings to the screening program in any country which has a screening program. And if there is a sibling, either twin or tablet, of infant diagnosed with methylmalonic acidemia, they should be rescreened because they may have the same illness. Methylmalonic acidemia confirmed through organic acid analysis for urine or plasma within the urine, revealing elevated methylmalonic acid. To establish the specific form of methylmalonic, additional studies to be done. These include vitamin B12 responsiveness or unresponsiveness, complementation analysis, C14, bobunate tracer, and probelamine distribution as well. Once the diagnosis is made, the patient should understand that treatment is lifelong, and it is not curative disease, and morbidity cannot be prevented as well. long-term management, monitoring. Actually, it is team management or multidisciplinary team, neonatologist, metabolic geneticists, and nutrition as well. And periodic blood and urine analysis is required, and genetic counseling is important or is indicated. Treatment, mortality rate is still high, especially in vitamin B12 non-responsive methylmalonic acidemia. Affected new patient or newborn should follow low protein diet, high caloric diet, and medical formulas and food that restrict isoleucine, valine, threonine, and methionine as well. L-carnitine may be recommended during period of illness. Child may need to be admitted to medical care to prevent metabolic crisis. Combined liver and kidney transplant may be curative for methylmalonic acidemia and renal insufficiency. The conclusion was methylmalonic acidemia or embryonic metabolism should be suspected, and there should be high index of suspicious. And if critically ill child, especially in the first few days of life, especially after introducing of protein, the embryonic metabolism should be put in differential diagnosis and should be addressed. The point for this patient that the first time we had the normal MSTMS, and when I called the consultant of metabolic screen with another sample, it was proved to be methylmalonic acidemia, and the case scenario she went, or the natural history went like that. But he told me that the first time to see baby in the first few days of life, I usually see neonates or children at the age of 6 months with severe mental retardation and severe affection. And actually, this baby came to us about midnight, and the sample was sent within 6 hours, not even 6 days or 6 months. And the high index of suspicious is important for early intervention and to reduce the side effects. Thank you very much. This is, and I know that it is short, and I'm very sorry for any technical issue. I don't know what happened. I usually do it, but I don't know why this time it went like that. Sorry.
Thank you very much, Dr. Sameh, for your very interesting presentation. And الحقيقة management كان excellent and very timely. At the time, طبعا, we didn't have the opportunities or for a program for neonatal screening, but I think this case was very well managed. Are there any questions on the floor?
Yes, there are many questions actually for me. What's the explanation that the first sample came negative, although it was done while the patient was acidotic, and the second sample came positive while the patient was not acidotic?
I don't know the technicality of the essay, but it was done of one of the biggest universities centers for embryonic metabolism. And the professor was one of the most senior in Egypt. There should be some false negative results. But the